Thank you so much for the introduction, and thank you for really an honor to be part of this symposium today. My name is Patricia Rodriguez-Lozano. I'm the director of the Women Heart Program at University of Virginia. And today the topic is going to be talking about chest pain after SCAD. And this problem is really frequently as seen, as Dr. Sarma mentioned before. And SCAD is not only about that acute event, as we are hearing over and over this morning. For many patients, it becomes a long-term diagnosis with ongoing symptoms, fear of recurrence, repeated evaluations, and a lot of uncertainty. So the goal of this talk is to walk you through how I think about chest pain after SCAD, how common it is, what we need to rule out, what mechanisms may explain persistent symptoms, and how a multidisciplinary program can help these patients to recover. So these are my disclosures. So the first point I wanted to make is that chest pain after SCAD is very common, especially that first year after the event. In this study from Canada, from the Canadian cohort that was published in 2022, ongoing chest pain was the most common symptom after the event. At 3 years follow-up, about 1/3 of patients still reported persistent chest pain. That is an important number because these are not just isolated symptoms in the first few weeks after an acute MI. The symptom can persist years after. So when a patient comes back to clinic 3 years after SCAD and said, I'm still having chest discomfort, this is not unusual. But at the same time, common does not mean benign. A common doesn't mean that we should just dismiss it. The clinical challenge is deciding how or when this can be a recurrent SCAD, when can this be an acute coronary syndrome, if this is another mechanism of ischemia, if this is about microvascular disease, vasospastic angina, or this is a no-cardiac or an overlapping contributor. So this is also a little bit more data to reflect. This is a study, a large US nationwide readmission database analysis that was published in 2021. More than half of readmissions after SCAD were cardiac related. The most common causes were acute coronary syndrome and chest pain. So chest pain after SCAD is not just a quality of life issue. It drives emergency visit, hospitalizations, repeat testing, and substantial patient anxiety. When these patients present with chest pain, we do need to keep a broad differential. Certainly, we worry about recurrent SCAD or ACS, but we also have to remember other causes of chest pain, like pericarditis, myocarditis, arrhythmias, maybe residual ischemia or scar, vasospastic microvascular disease. The key is to approach these symptoms in a structured way rather than treating every presentation as either recurrent SCAD or nothing cardiac. There are many algorithms out there for recurrent chest pain after SCAD. I like this one because it separates two major clinical scenarios. On one side, we have the patient with a new or acute presentation, symptoms that look like acute coronary syndrome, new ECGs, changes, troponin elevation or instability. In that situation, most of us are comfortable. We evaluate urgently for acute SCS or recurrent SCAD or extension of the primary dissection. The more difficult group, I think, is on the other side, the patients with a stable but persistent recurrent chest pain. These are the patients who have symptoms every day, every week, or every few months. They may have normal troponins, normal ECGs, and low risk or even normal stress testing. That group can be very frustrating for both the patient and the clinician. Often we start with non-invasive testing. We have different flavors of that. We have nuclear stress testing, EKG stress testing, coronary CTs when appropriate, cardiac MRIs, PET, or other modalities depending on the clinical situation. If testing is high risk, then we escalate. But many patients have low risk testing and still have symptoms. So here, I think thinking about other mechanisms become important. So this is just a practical framework that I use. So the first question is this is acute or high risk, or this is a stable recurrent angina? For acute or high risk symptoms, I am concerned when the pain is similar to the index SCAD event, when symptoms are crescendo, they are getting worse, when there are new ischemic ECG changes, rising, of course, troponin, syncope, maybe heart failure, or some kind of hemodynamic instability. Those patients need to urgently manage as a ACS, acute coronary syndrome, and SCAD evaluation. But there is another group, patients with negative ECGs and troponin is, also are negative, recurrent daily or weekly symptoms, normal or low risk stress testing, and symptoms that may occur at rest with mental stress or emotional stress, or sometimes even with exertion. For those patients, the goal shift from rule out something like a catastrophe or to phenotype the mechanism. The message I want to emphasize in this is do not dismiss the symptom just because chest pain is common after SCAD. First, do the safety screen. Then, if the patient is stable, move toward mechanism-based evaluation and treatment. So this is the case of a patient from my clinic. And okay, so this is a Mr. H. She's a 68-year-old woman that she did have history of hypertension, hyperlipidemia, and diabetes, things that are sometimes not common to see in our SCAD patients. She did have also history of a non-STEMI related to LAD SCAD a few years back that was medically managed, and she was very stable. And until now that she presented 3 years after her acute event with persistent angina and dyspnea for around 2 to 3 months. And she was on this medication, aspirin and carvedilol and atorvastatin, because of her history of hyperlipidemia. So now the question was if this is a new episode of recurrent SCAD, or she now developed atherosclerotic disease, or this was more a new residual ischemia, or this is another kind of mechanism. So what we decided to do initially, she got a stress cardiac MRI, and this is her cine images. As you see, there is some wall motion abnormalities in the area of that she had previously her episode of SCAD. This is her first pass perfusion images, and there was not really a perfusion defect at the visual assessment, but with cardiac MRI, we can also get quantitative perfusion, and this is the polar mapping of her quantitative perfusion, and her rest flows were 0.9, her global stress flows were 1.5, and the ratio of that was her perfusion reserve that was 1.7. So we have a cutoff of 2 to consider it normal. So hers was quite diminished, was 1.7. And this perfusion reserve being diminished in the absence of obstructive epicardial disease suggests coronary microvascular disease. There is an inappropriate augmenting flow during stress. So in this case, we treated her as coronary microvascular dysfunction. And we started therapy with a vasodilator, with lisinopril. And then we also have to add another medical therapy with isosorbide, with a nitrate, and she improved her symptoms and she was feeling better. So with that, I just wanted to quickly summarize what is ANOCA. ANOCA is angina with normal coronaries. And this is just to emphasize that there are different mechanisms that can explain angina in normal coronary. And this is also applicable in patients post-SCAD. When we have ruled out recurrent SCAD, we should think about if this is related to other kind of mechanisms like microvascular disease, vasospasm, endothelial dysfunction, or overlap of all of these. There is some studies that have looked at this specific in patients with SCAD, and in this study that was it's a small study that was previously looking at patients with a prior history of SCAD and recurrent angina, and they performed an invasive physiology testing using adenosine, and they measured coronary flow reserve and IMR. And the key point here is that patients with a prior history of SCAD, there was an important number of patients, around more than 70% had a positive study suggesting a low CFR less than 2.5 and IMR more than 25, and in at least one coronary vessel suggestive of coronary microvascular disease. And this slide takes a concept, this concept further. Here is a study that looks at endothelial dysfunction using a non-invasive assessment with reactive hyperemia peripheral arterial tonometry that is called this RHPIT. And even though it was a non-invasive study, it suggested that patients with prior SCAD had a poorer endothelial function compared with matched controls. And then just putting all together, what I wanted to emphasize here is for patients that are stable, we should try to phenotype the mechanisms. For stable cardiac causes, we should consider a broad differential. First, vasospastic or endothelial dysfunction. The patients may have rest pain, usually emotional or mental stress triggers. They are very nitro responsive. They might have cyclic or catamenial symptoms. So in these cases, many times I use empiric calcium channel blockers or ranolazine, and we have, in our experience, a very good response. Then we have another phenotype that is the coronary microvascular dysfunction. Usually these patients have more an exertional or dyspnea as their main symptom. And in these cases, we can utilize non-invasive testing, quantitative perfusion, PET or cardiac MRI to get the diagnosis. And third, if we think about residual ischemia or scar or incomplete healing, in these cases, many times also stress testing or CCTA will help us to differentiate what is the phenotype and the cause of chest pain. And really quickly, I just want to emphasize things that have been said before. Think about the other non-cardiac contributors of chest pain, anxiety, PTSD, hypervigilance can amplify symptoms. Maybe many of our SCAD survivors live with fear of recurrence and sleep disruption and avoidance of activity. So all these things can exacerbate their symptoms. So the first year after SCAD is extremely important. Have a conversation about all of this also, and have a multidisciplinary approach during that first year is so important. For chest pain, we really manage these multiple mechanism pathways, different medications, but not only anti-anginal is important, psychological support, peer support, and cardiac rehab, as Catherine mentioned before. And just one word on what is the I think the place for coronary functional testing is an area that is very exciting. Many of us, we have thought about this. Unfortunately, for coronary functional testing, it's an invasive study, and that includes not only adenosine testing, but also a provocation testing with acetylcholine. That there is a concern about safety in these cases. I think there is a very interesting area. There is no published studies specifically of coronary functional testing and safety in patients post-SCAD. Anecdotally, some of us, we have done it in our practice, but really we have to be mindful about the increased risk of iatrogenic dissection. So I will say that this is a promising area that we need more studies. But this is something that maybe in our iSCAD group can think about mostly. So this is how I will integrate CFT conceptually into post-SCAD algorithm. First, for any new or changing symptoms, we have to exclude recurrent SCAD or ACS. Second, if the patient is stable or there are no high-risk features, we can begin mechanism informed empirically. We can, if the phenotype suggests that we are dealing with vasospastic angina, thinking about coronary calcium, calcium channel blockers, or thinking about cardiac rehab, the triggers, psychological recovery, and third, if patient persists despite several months of appropriate therapy, maybe in those cases, in very elective cases, think about invasive coronary functional testing. And just to finalize, this slide brings us all back or the larger goals of long-term SCAD. Long-term management is not just about preventing recurrent dissection, although that is obviously very important. It's also about alleviating residual cardiac symptoms, helping patients return safely to physical activity, screening for associated vascular conditions, addressing the psychological impact of SCAD. That is why SCAD care fits so naturally into this multidisciplinary model. A patient may need a cardiologist, a vascular medicine, cardiac rehab, exercise physiology, behavioral health, pharmacy support, nutrition, and sometimes maternal fetal medicine, as we discussed in our previous session, cardio obstetrics, and all this is part of the recovery in our patients post-SCAD that happens not only acutely in the first months, but through years. And just quickly, just to finalize, I wanted to present to you what we are doing at UVA. We have multidisciplinary care with different clinics. We have a clinic that is specifically for patients with SCAD, and we have also this combined clinic with vascular medicine. And in this clinic includes a multidisciplinary approach with nutritionists, exercise physiologists, and mental health providers and our research team. And many of these is provided by telehealth. And then finally, we also believe in the importance of cardiac rehab, and we have created specific protocols in our patients with SCAD and FMD. And here are my take points to finalize. Remember, chest pain is important. So the main thing is rule out ACS and think about other endotypes and phenotypes in these patients, and really comprehensive treatment necessitates a multidisciplinary strategy encompassing cardiac rehab, psychological support, and anti-anginal therapy. Thank you so much.